Well, this patient has an obvious cataract. This is the right eye. I'm sitting temporally. Notice that the blade on the side port blade is superiorly. And that's so if there's a Bell's phenomenon, it won't enlarge. And you'll get Bell's phenomenons once in a while during surgery, as we all know. Fixating the globe with my left index finger. And this 2.4 keratome, I'm advancing it. It's about a 15-degree angle to the sclera. I'm advancing it to that line right there. That's 2 millimeters. And I dip down just a little and enter the chamber. Now, you can see that anterior subcapsular opacity there. Might the rhexis go out over it? Yeah, probably. Will I be able to see the capsular rhexis when it goes out over it? Maybe. Maybe not. Well, if I wanted to be sure, and I do, I'm going to inject some trypan here. So there's the air comes out of the syringe first, and then comes the trypan. How long do you have to leave trypan in an eye? Seconds. 5, 10 seconds is plenty. Then we'll use the lidocaine. This will sting a little bit. That's what you want to tell the patients. Okay, because it does, but not for long. Try to look straight at the light. Good. This happens to be her only eye with central vision. The other one has a macular hole and peripheral vision only. Now, there's another thing you can do with anterior subcapsular opacities to get them out of your way. You can move them. Yeah, this isn't generally known, but watch. You can just inject OVD against them and move them into the periphery. They won't stay there long, but they'll stay there long enough to do your rhexis. Provisc now is on a 25 gauge disposable needle. So I've started the capsular rhexis tear here. I would expect that you notice the stria in the anterior capsule when I began the rhexis. So let's watch that here. There's still some stria there. I'm going to go inside the opacities. And I'm going to make a rhexis that's around 4.5 or 5 millimeters. Now, like most patients who only have one seeing eye, they tend to defer cataract surgery along the road. So they wind up with a denser nucleus, and that's what we'll see here. It's about a 3+ nuclear cataract at slit lamp. So now I'm going to use a flat 23 gauge hydrodissection cannula that I designed. Pretty simple design. It's available from Crest Point Management, and I have no financial interest in any of the instruments that you're seeing me use here. And now I'm going to do viscodissection for 360 degrees because I'm not convinced about this zonular status, and I'd like to make a nuclear sandwich surrounded by viscode. And especially I want the viscode out into the capsular fornix. Now I brought the balanced tip of the Centurion phaco system into the field, and I'm checking infusion. And you can see that the infusion's good on the right side, not so good on the left. So I rotated the sleeve a little, and then we'll do it again, and now we're getting better flow out the left side, but not perfect. So now I've got really good flow out both sides. And I'm going to actually position the globe by using the McCool Big Ball Chopper, also available from Crest Point, in the side port incision. Insert the phaco. And then go to position 1, wet cornea. Now with the globe rigid, it's so much easier to push the chopper into the eye with a quick little motion like I just showed you there. This is a tight side port incision, relatively speaking. It will leak 1 to 4 cc's a minute. Okay, dense nucleus being held still. You can sculpt the dense nucleus, wet the cornea, please, so much more quickly, efficiently, if you hold it still. Now there's some OVD in my way here, so let's go to quadrant removal, because I want a real clear view as I sculpt deep here. And now back to sculpt. I think you can probably appreciate that the view is now clearer than it was before I removed that OVD that had some small lens particles in it. And now what I'm looking for as I focus and zoom is a good red reflex in the bottom of the bowl. And I pretty much have one right there in the center. That's where you need it. And now I'm going to impale the nucleus. So watch the screen if you want to. Position 1 goes to 3 and then 2. And then I hold it while I chop it. Okay? So we're going to do that a few times. Chopper up over the sculpted wall, over the edge of the nucleus, wet the cornea. And I'll go position 3 to 2. Okay, so there's my segment. Now I want to remove that piece because I want to decompress quadrant removal, the capsular sac. Because I'd like all of my subsequent chops to be done in a decompressed sac out of consideration for the lens zonule. Okay, so I'm going to now rotate this nucleus bimanually, chopper out over the equator, position 3 to 2, chop. And one more time, and then I think we're ready to remove these quadrants. Good. Now you can do that maneuver impale at lower vacuum and flow, like I used for sculpting, if you want to rewind your video. On denser nucleuses, I'll sometimes stay at the higher flow and vacuum levels, particularly the vacuum levels, so I get a really good fix on that segment. Now what I'm trying to do here as much as I can is get the vacuum level up as you see it now before I step on the pedal. And that way I remove more nucleus for the amount of ultrasound that I use. Now this segment is fairly large, but this chamber is very deep. So otherwise I would have divided it. So you can see that I don't just sit on ultrasound. Even when I'm making some progress, I'll stop periodically. And you know what that does? It lets your tip cool off. Now this is a cool functioning tip. It's a torsional, and so there's very little, relatively speaking, thermal generation compared to non-torsional tips. But that doesn't mean you should, try and push the envelope with anything. So every so often, if you happen to be impaling and buzzing away, pause for a second or two. Fluid flows around the tip, cools it. Why not? So we're now ready to remove the remaining cortex. And you can see it's mostly subincisional. There's two reasons for that. Viscodissection is more thorough inferiorly, and the phaco tip is pointing inferiorly as you're removing nucleus. So cortex, if it's at all loose, will tend to be attracted. So 90-degree INA tip, 0.25 port, and just removing the cortex. Now next I'm going to take these little nuclear or epinuclear chips out, and they wouldn't be aspiratable without deforming them. So the spatula is going to do the deformation for us, and then we'll get them out. You could also leave them in there and remove them with visco expression, if you will, either before or after IOL insertion, but I'm doing it now. Okay, next step. You can see all of the opacification of the anterior capsule, and that's subcapsular. So I'm just going to vacuum that off gently for about 180 degrees. Why do you do that? Well, it doesn't change your PCO rate. but it does decrease your chances of capsulorhexis contraction. And capsulorhexis contraction is not a good thing. It's not just a cosmetic blemish. It stretches the lens zonule. And if you have a weak zonule, why would you want to put any traction on it? So we won't get capsulorhexis contraction where we did that. Subcapsular epithelium removal. Now I'm injecting Provis. The posterior capsule is really clear, so I don't have to do anything there. And the capsular sac is quite inflated. Now I'm positioning the globe right where I want to position it to see well as I inject the IOL. This is a Monarch D as in David cartridge. As soon as I can see the tip of the cartridge in the anterior chamber, I don't have to go any further. And while it's slowly unfolding, that's your chance if you'd like to position the IOL at approximately where you'd like to leave it. And here, I want to leave it horizontal. One haptic remains adherent to the optic. Happens all the time. You could wait it out, it'll release. You could grab the terminal bulb with any forceps and that'll release it. Or if it's still stuck, you can stabilize it with the INA and just sweep it off with any instrument. I did it with the spatula end. I could have done it with the chopper end. By the way, there's a spatula on one end of the chopper, as you just saw there. So it's a dual purpose instrument. And I'll just palm it during the procedure and then flip from one to the other depending on what I want to do. I'll use the spatula to rotate an IOL. And you've seen me use the chopper, obviously, for nuclear chopping purposes. So now we've got the IOL horizontally located, and it only remains to do some stromal hydration. And I've got the syringe in my left hand in preparation to do that, so that if there were a tendency for the chamber to shallow, I'm there within 2 or 3 seconds to prevent the optic from getting up near the endothelium. And by the way, if I really thought that was going to be a problem, highly myopic eye, poor scleral rigidity, I wouldn't remove the OVD from the anterior chamber. I'd irrigate it out the way I'm irrigating out the remnants of the OVD from the angle right now. I can tell you that the intraocular pressure is nice, well maintained, and you can tell that if you use a loose glove. See how this glove is loose on my index finger? If that were really tight, my proprioceptive fibers would be numb. They wouldn't really be able to tell the difference between the inside of the glove and the eyeball. So that's why I wear a glove that's a half size larger than I need. Try it, you might like it. So there's the vancomycin 1 milligram injection given into the anterior chamber, and we are finished.